All our dear friends in Plastic Surgery Videopedia. Today we have Alessandro Gennai from Bologna, Italy, and he's going to talk to us about some novel new approaches to facial aging of the upper third of the face. I've seen his work and it's really exciting. You got some new ideas about doing things, and it prompts me to think about one of my sayings that I'm so happy with, and that is that youth is the capacity to adapt to change. So the people watching this who are over 50, they may not be so interested in doing what you're doing. It's the young people who haven't really gotten their practices established who want to do new things and better things. It's not the professors. That's been my observation. And so what you've been doing is certainly new. So we have the video, which you'll see in a few minutes. But it's good to have a chat with him. And I want you to feel out there that you're sitting with us, and that the questions I ask him, he'll answer to both me and you. So you're part of this. You're part of this conversation. So Alessandro, tell us how you got to doing this facial rejuvenation of the upper third of the face. What prompted you to start doing that?
Yeah, I think that in my philosophy, my way of thinking is that the facial rejuvenation has to be a kind of an artistic work. And so, unfortunately, most of the results that I can say, it's a little bit far from an artistic work, because a lot of procedures aim to pull the skin and to cut the skin. Mm-hmm. And anyway, I started to think about it, and I think that to choose the good procedure to have an artistic and very natural result in facial rejuvenation, there is three answers, very simple answers, questions that you have to answer. The first question is, how old now? How old is our patient now? Mm-hmm. And the second one, in which part of the face is more involved in facial aging? And the third one, and what happened in this part of the face. And to answer to the first question, how old is our patient, in my cases report of more than 400 cases of surgical procedure for facial rejuvenation, the average age is 46 years old.
Yeah, right.
Yeah, and so it's very young, the person that asked to us to
yes.
facial rejuvenation.
Yes.
And the second question is, which part of the face is more involved in facial rejuvenation, in facial aging? And if you take a picture of your patient when she was 20 years old, for example, and compare with your patient, it's very easy to understand that the most important part involved in facial aging is the periocular area, the malar and zygomatic, and the periolar area. Mm-hmm. In one word, the central part of the face is more involved in facial aging. And so, at the end, the other question is, what happened in this part of the face? And so we tried to put a score of the different area, in my cases, to evaluate the skin aging, the loss of volume, and the descent of tissue. And it's very interesting that this survey showed us that the first problem is the loss of volume. Mm-hmm. The second is the skin aging, mm-hmm. and only the third one is the descent of tissue. Mm-hmm. And so for this reason, I try to think about a technique that can correct this kind of problems. MIVEL, my technique, the minimal invasive vertical endoscopic lift, is a technique addressed to achieve a natural repositioning, not pull, but repositioning the tissue in vertical vector by endoscopic procedure. And the SEFFI, another my technique, is a superficial enhanced fluid reflecting injection, is a technique addressed to achieve restore the volume and to regenerate the skin. Mm-hmm. In one word, I think that to have a natural and artistic result, you have to restore the volume, regenerate the skin, and repositioning the tissue, the R-cube technique. Mm-hmm. This is my philosophy in the facial rejuvenation. There is not cut skin, not pull skin, but to reposition, to restore the volume, and very important to regenerate the skin.
Yeah, I was impressed with your comment that in the past we've been approaching facial aging from the periphery here. Yeah. Whereas when all the problem really lies in the center. Yeah, so why not go to the center?
This one is the start point of my way of thinking. Why I have to approach my facelift from the lateral part of the face when the problem is the central part of the face.
Exactly. Exactly. That's really clever thinking. And see, this is youth. Youth is the capacity to adapt to change. You're youthful and you want to change the traditional way. The old guys don't want to change the traditional way because they want to get better at the old-fashioned way. But I think that we need to address the fact that the real problem lies in the center of the face. All right, let's talk about the endoscopic part. I've had some experience with endoscopic brow lift, and I've loved it. It's just a wonderful thing. And I was happy to see you do it pretty well, much like I do. And that is, you've got to divide that periosteum along here.
Yeah, of course.
So otherwise it won't stay. Some of my dear friends in New York wrote a paper saying it didn't work, that operation didn't work. And I thought to myself, and I wrote a note back, well, they're not doing this the same way I'm doing it. But I've never put that suture in. You've done that clever suture. Tell us about that.
Yeah, I think that the first, when I started this endoscopic procedure, more or less in 20 years ago, I got that the most important thing is the completely release of the tissue.
Right.
Because I saw a lot of time a colleague that said, oh, come on, the endoscopic procedure doesn't work anyway. But a lot of colleagues use endoscopy only to see what happened. But it's not this. It's not this. The endoscopic procedure is a very good procedure to use to completely detach the periosteum from all the frame of the orbit. Because the periosteum is a very strong tissue. Yeah, and so if you leave only one little piece of periosteum attached to the orbit frame, the tissue cannot move in the upward position. And so the first thing is to completely release the orbit frame and the tissue. After that, it's very easy to move the tissue and to fix the tissue. In my practice, I used a lot of devices to fix the tissue. At the beginning, I used the tunnel in the skull. Yeah. After that, I used the endotyne procedure. But at the end, I got that it's not so important, the device, the fixation device. The only thing very important is to detach all the area to have a very good dissection in the endoscopic procedure. After that, with my kind of fixes, a simple sutures with stitches with 3/0 vicryl. So it's very easy, because the long-lasting result is guaranteed not by the strength of the devices, but the adhesion, the healing adhesion of the tissue. And that's it.
It's so interesting because I've used all these devices and ended up back where I started with the screw and the staple behind the screw. But I asked one of my orthopedic friends, because people said, oh, how long do you leave the screw in? Well, I said, well, I left it in 5 or 6 days, but it doesn't matter. Oh, you know, you need to leave it in 3 weeks. I asked one of my orthopedic friends, how long does it take periosteum to stick down? He says, oh, I don't know, maybe 6 hours or...
This is true.
So the whole idea is to reposition that tissue and let the periosteum adhere to its underlying bone.
Yeah.
And it'll stay. And so the fixation part is not one of the big factors. Also, that frontalis muscle is pulling things up.
Yeah.
So maybe we don't need to fix it.
Yeah, absolutely.
That's a
good question. Frontalis muscle move like this.
That frontalis muscle is pulling that.
Is our friend.
Exactly.
Is our friend.
But I've never used that clever suture that you put across there. Tell us about that.
Okay, the system is very simple. I use three kind, or I use one suture is a coronal suture from the incision of the lateral side. I put the stitch on the other side and I close in the middle. This one is to elevate the tail of the eyebrow. After that, I put another stitch in the paramedial position. And this stitch is very easy because it's enough to have a little bit of, with a blade, 11 blade, I cut the skin through the periosteum. After that, I go with a needle, the rubber band needle. I go inside here, under the periosteum, and go out from the incision, the paramedial incision. After that, I take inside the vicryl. I grasp the tissue, the periosteum in this part, and I put the suture backward. After that, I tighten the periosteum and the back periosteum. And so it's very easy to fix. And after that, you have only to wait for the healing. And the third suture that I use when I need to have a repositioning of the malar area is like this, in the same way of the paramedial stitch. I made a little pinch with a blade, 11 blade. I go inside with the rubber band. I go outside from the temporal incision. I arm the suture. I go inside. I grab the tissue and I go back again. And I fix on the deep fascia, on the deep temporal fascia.
Yeah, this is all demonstrated in the video. So
yeah,
tell me what you do about the upper lids.
About the
upper lids.
Oh yeah. A lot of time I don't need to cut the skin, because in a 46 years old patient, a lot of time the redundancy of the skin in the upper lid is more from the descent of the eyebrow than the real skin, and so I prefer to repositioning the eyebrow to fill with SEFFI the head and don't cut skin. I try to cut very few skin.
You see, I've given a talk on numerous occasions. I haven't written it, but the title is Upper Blepharoplasty. I've done the wrong operation 3,000 times because I would be excising skin and excising fat and sewing it up and getting a cavity of the upper lid, which I thought was wonderful. It was terrible, and I did it so many times. I'm embarrassed to say it, but I did. We learned that from Salvador Castanades, who was doing it in the 50s. And it took a long time for us to realize that an aging upper lid is not one that's got too much fat. It's got one that doesn't have enough fat.
Yeah, exactly. And so you have to recreate the volume and regenerate the skin or reposition the eyebrow more than to cut the skin.
Exactly. That's why I'm so excited about your work, because you're doing and talking and writing about things that I've been thinking but have never written, and because you're the one. And I'm overjoyed to promote this, and I want everybody out there to understand that it's a new way. It's a new thought about facial rejuvenation. You've got to correct the problem, and the problem is loss of volume. Yeah. The problem is aged skin, and the third problem, and the least significant really, is the descendancy of some of the skin. And we might want to reposition some of the fat, but not the skin. The loose skin is not the problem. So, well, tell us what. Now let's pretend that somebody in a long way away from Bologna, maybe some West Texas, somebody in West Texas, is watching this, and they think that they're going to do that. Tell us the first steps of caution that they should take. Where should the beginner be cautious? Too much elevation? Where should the beginner be cautious? It's because it's a simple concept, but all simple concepts are difficult to do.
You want to know what is the
potential problems?
Okay. When you see your patient, you have to touch the face of your patient. And a lot of time I ask to my patient to bring with her a picture when she was 20 years old.
Good.
It's extremely important, because you have not to trust to change the face of the patient, but only to rejuvenate the face.
Right.
And the only way to deeply understand in which way you have to go is to see the patient when she was 20 years old. And so you can study the volume, the position of the eyebrow, the position of the tissue. And after that, I don't like the overcorrection. Mm-hmm. I put the tissue in the right position. I restore the volume, but is the picture of the patient that lead you to the right procedure and to the tension. And when you have the face of your patient in front of you, you have to touch the face, you have to try to move a little bit the eyebrow and to talk with your patient. Talk with the picture of your patient. And so, because the patient, a lot of patients come to your office and ask, okay, I want like this, but it's not like this.
They don't really want to look like
that. No, it's not really. And so you have to talk with your patient and to explain what you think about her face. And so it's very easy. The procedure is very, the endoscopic procedure you can, is very easily to adjust, to put in the right position all the tissue. When the patient is lie down, it's very easy to understand where to put the eyebrow, where to put the volume. You have to draw the face of your patient, and after that it's very natural, the result.
Well, I'm very excited about this. I'm very happy to have you here with us, Alessandro.
Thank you.
This is Alessandro Gennai from Bologna, Italy, and he has a new way of addressing the upper third of the face, which I think is very exciting because he addresses it directly. And he feels, as I do, that the aging of the face is primarily in the central third of the face. It's not in the periphery. And he's addressing that directly, which is a great step forward. And the greatest opposition to progress is the comfort zone. So those of you who are comfortable out there doing it the old-fashioned way, you'll keep on doing it that way. But you young people who want to do it a new way, a more progressive way, and want a more direct way, will enjoy learning more about Alessandro Gennai and his work. And we have a wonderful video for you to follow this. And if you have any questions, please write me at tbigsmd@aol.com. And if I can't answer your questions, I'll forward them on to Alessandro, and I'm sure he will. So thank you once again, Alessandro. It's a pleasure. It's an honor to have you with us.
Thank you very much. It's an honor for me.
And thank you all folks out there for listening. Goodbye.